Good morning, everyone, and welcome to CME Palooza Spring. I am Scott Kober, one of the co-producers of CME Palooza. You will be seeing myself and Derek Warnick, the other co-producer, throughout the course of the day. So thank everyone for joining us today for our first session of the spring meeting. This session is entitled Straight from the Horse's Mouth: Learning Preferences of Healthcare Providers, and this session is being sponsored by the Global Academy for Medical Education. So as with all of our sessions, I first would like to thank all of our wonderful sponsors of CME Palooza Spring, our gold sponsors, Genentech and Prova Education, our silver sponsors, ASIM, Forefront Collaborative, Global Academy for Medical Education, and Platform Q Health Education, and our bronze sponsors, ACHL, Clinical Care Options, CMEology, Helio Education Lab, Highmark CE, Impact Education, Integritas Communications, Connective, Primary Care Network, PVI, and RMEI. With all of our sessions, there are 3 ways to ask questions. If you want to say anything or ask questions to any of our presenters. So you can use the Educational Measures text line to send in the question, and the number is 267-666-0CME-0263. You can click on the Google Slides link that is found on the same live page you are using to actually view this broadcast, or you can tweet your question to us using the CME Palooza hashtag, and please use capital CME lowercase Palooza, or else Derek will get very, very mad. So brief speaker disclosure, just be mindful that the opinions, discussions, and conclusions of our speakers are their own and do not represent an endorsement or position of their employer. And with that, I am going to turn this over to Amanda Glazer, the Director of Medical Education for Connective, to kind of get us started.
Well, thank you, Scott, and good morning, everybody. Welcome to CME Palooza Spring 2017. I'm really excited that in the voting process, everybody selected our talk with in our interview with Dr. Paul DeGramji. He's a family physician at the Collegeville Family Practice in Collegeville, Pennsylvania. So the first part, a little bit of an agenda today for our talk. I will be reviewing a few data slides from some published data that I actually conducted at my former company, Global Education Group. This was published in the Medical Meetings magazine in 2013. And I thought this was a good leeway into the interview that we will follow up in the second half of our presentation today. So just a few slides reviewing the value of CME from a healthcare provider's perspective. And so you can see on this first slide that we asked over 1,400 healthcare providers, and this ranged everywhere from physicians to nurses, pharmacists, nurse practitioners, what value they place on the following sources of information and education that supports improvement of their professional practice and patient outcomes. And you can see that ranking from not valuable to valuable, accredited CME activities ranked the highest over some of the other sources of education and information that healthcare providers are presented to on a daily basis, such as speakers bureau programs, medical science liaison visits, as well as direct-to-consumer advertising. And so these healthcare providers did find CME and accredited CME activities to be the most valuable for their practice and also improving patient outcomes. When asked the number of hours that healthcare providers complete CME, we can see that almost 90% complete more hours than what's required for their state and or board licensing. And so we know that these healthcare providers are really engaged into CME. They're completing CME activities for more than just to complete their license. And Scott, if you go to the next slide, we can see some of the reasons that the primary reasons why they complete more CME than what's required is that they're learning more about new and engaging therapies. And so these healthcare providers are really seeking CME to help them with some of the new information that's coming out on a daily basis with those new and emerging therapies, clinical trial data, as well as complex treatment options and being able to treat those complex patients. Seeking additional unbiased evidence-based information is also top on their list, as well as learning beyond their core areas of expertise. And so I think this is especially true for the family practitioners and general practitioners seeking education that is outside some of their core areas where they may be presented with patients that are not necessarily something that they've dealt with on a daily basis. And so seeking CME, because it is evidence-based and it's information that they can trust, are other reasons why they seek completing CME activities. We also wanted to look at different educational formats, and so these next set of questions looked at the difference between live versus enduring or online education, and looking at some of the reasons why healthcare providers participate in these types of activities. We can see that for live activities, it's really about the professional interactions, not only with the faculty, but also with their peers. And also, many of them believe that it is a more effective format for their learning styles. And so a lot of the healthcare providers do enjoy participating in live activities. And if we go to the next slide, we can see some of the reasons for participating in online, print, or enduring activities. And this makes sense. It's really looking at cost considerations as well as time savings. And so we know that the healthcare provider has a busy practice. It's not always easy for them to get away from their office. And so being able to go online, view print activities, and complete their CME requirements, as well as learning some of the information that way, is also very important. We do see that it is more effective format for learning for a few of them. Maybe not so quite as high of a learning preference for format as the live activities, but we do know that there are a large population that do enjoy the online or print activities. However, if we look at barriers to learning formats, again, no surprise here, we can see in the live education, it's really looking at time constraints, cost of travel, schedule conflicts, and loss of income from being away from their practice. And so we also know that a lot of times reimbursement issues and just the travel and being away from their family and their practice is one of the major barriers for participating in live activities. And that doesn't mean that enduring education isn't free from some of their barriers and challenges as well. We can see time constraints for both activity formats. Again, we just know that it's a busy practice, and being able to fit in an hour here and there for completing CME activities can be tough for some of the providers as they are trying to work with as many patients as possible. Some feel that enduring education has a lack of educational value. There are technology challenges, especially with the advent and the changes and differences in online formats and in engagement of those activities for learners. There's always going to be a technology challenge. And we've also heard that there's lack of feedback. And so I think that's another, again, those interactions with peers and faculty at the live setting is something that's missing in an online format. We are seeing providers that are able to provide some feedback for the learners, whether that's immediate or as a follow-up. Being able to provide that to learners in an enduring format has greatly helped those types of educational formats to help the learners feel more engaged and be able to get the information that they need and the questions that they need answered. So if anybody, as Scott mentioned, has any questions about the data that I just shared, feel free to jump in and ask away. I do know that Global is presenting updated data this May at the AIS meeting in a couple weeks, so be sure to check out that session and you can see some of the updated CME value data that will be coming out of that group. But moving along now, again, I'd like to introduce Dr. Paul Degramji. We are going to start our interview portion. So again, we want to keep this interactive. So if anybody has any burning questions for Dr. Paul as we're going through the interview, feel free to jump in and ask away. So thank you for joining us, Dr. Paul, and welcome to CME Palooza.
It's my pleasure. What an unusual format. It's great to be here.
Wonderful. So just jumping right in, looking at your involvement in CME activities, I know you have provided help and guidance and served as faculty on many CME activities.
Yes.
How many CME activities do you participate in as faculty, or how many have you participated in over the last few years?
Well, I've been doing this for, gosh, well over 20 years. I can't believe it, but it's been actually wonderful. I love the ability to share information with my colleagues, and fortunately, I have been able to develop a way that I think has been effective. It depends on the year. Some years I'll do up to 30 or 40 CME venues, predominantly live venues, some of them online. Other years it may go all the way down to 10 or 15. I would say it averages around maybe 30 or so per year.
Wonderful. And then based on the data I just shared, how many hours of CME do you complete as a learner each year?
Well, actually, a couple of weeks ago, I was entering in all of my CME that I participated in, because as a family practitioner, I have to enter in all of my CME that I've done over the last couple of years or so in order to be considered board certified. I'm supposed to have 175 hours or so, but I was surprised to see that I had well over 250 hours. I would say that I average per year maybe about 50 to 75 hours, and a lot of it kind of depends on, number one, what's out there for me that I enjoy. Number two, what I'm invited to. A lot of times when I go and serve as a faculty, I'll stay on for, let's say, a weekend venue or something going on in a live presentation. And sometimes I get, well, every day I get emails for a 15-minute blast or so of CME. I'll do about 2 or 3 of those almost every day, just because they're interesting. So it varies from year to year, but I would say about 50 to 75 per year. And, it's interesting that the data that you presented earlier, Amanda, and that a lot of clinicians, they'll get a lot more CME. I'm not surprised about that because, we have a relatively cerebral field of practice where we want to learn, we want to know. We've gone to school for umpteen years, so that desire continues. So if we see something interesting, we'll want to go about it. So it's not just about completing the exact hours that are required of us. Many of us do have an innate need to know more because we want to do better.
Wonderful. And referring back to the CME value slides that I presented, what value do you personally place on continuing medical education as it relates to your practice and patient care?
Well, I put a lot of value on getting CME because, like I said, it's not just about learning what's up to date. It's not just learning about what I need to know to satisfy, let's say, the different people that are looking over my shoulders. But I need to know because, like I said, I need to know. It's just part of doing the right thing. We're in a very noble field, I like to say, in medicine. We're doing something really important for people, and we take that very seriously. So knowing what we have to know goes above and beyond just satisfying a CME requirement, or we have insurance companies that look over our shoulders and say, what kind of CME did you do? And sometimes we have guidelines for the corporation that we may work for, etc. But there was one other thing that I also wanted to comment on, which is, you asked me how many hours of CME I've completed. I just wanted to make sure that I also I made some notations about this. I mentioned that the things that I've done are not just attending CME conferences, but also writing in journal articles, and also being a peer reviewer in journal articles, teaching students, some webinars, and as well as, like I said, reading journals. So there's all these different CME activities that I participate in over the course of what I'm doing on a year's basis.
How is CME better than other sources of info that you are bombarded with on a daily basis, whether it's from pharma reps, which you see online, on TV? How does CME compare to those?
Yeah. Well, whenever you have a pharma-sponsored program, they're very targeted. They basically want you to learn about a medication that they have, which is very valuable. It's extremely valuable to know about a medication's ins and outs. And nowadays, with all the regulations that we know about, we know that it's going to be fair balanced. So that teaches us primarily about the medication itself, with maybe a background of disease state. But nowadays, with a lot of the regulations, that the disease state education is really not there. So again, they're very, very valuable to tell you about the medication, but it's very, very targeted. But as far as CME is concerned, it's more about disease state and about all the different kinds of treatments that are available. So whenever you have a CME venue, let's say whatever it is, let's say a diabetes or diabetes-related neuropathy or coronary artery disease, atherosclerosis, hypertensive kidney disease, gout, whatever. They are about disease state and then all the different aspects of management that are involved, and medication is just one of them. But like I said, with the pharma-sponsored situations, they're very good, but it's only about medication. But you also asked about other types of things like online activities. I think they're good, and a lot of people like it a lot. I like the idea that I can do it whenever I feel like doing it, and I can stop and start and that sort of stuff. But you also asked about television. Well, I rarely watch television to get any kind of medical information, and chances are, if it's TV, it's going to be for lay people, and a lot of information on TV is very skewed or very old.
Great. And there's a lot of scrutiny from the federal government and with the Physician Payment Sunshine Act, and they've tried to carve out a section for CME because they feel that CME could be potentially biased. what, in your opinion, would be the downfall if we, had to get rid of CME, or if CME got so regulated that it wasn't available for everybody? How would that affect healthcare providers in their practice?
Well, let me preface that by saying that continuing medical education is essential to being a good medical provider. You have to do it. Things change all the time. They change yearly, monthly, weekly, even daily. You have to keep up. And in order to be a good clinician, you absolutely have to do that. Continuing medical education and all the different venues we talked about are the way that we do it. Now, whether they are sponsored by this, sponsored by that, whatever, they are all very, very important. So if there's more regulations in what we have to learn, we have enough regulations. We have enough people looking over our shoulders, telling us what to say, what not to say, what we have to do, what we don't have to do. Again, as I said earlier, being a clinician, being a physician, it's a very noble field. We take our job very seriously, and we want to have as least amount of interference with it as possible. I don't like governmental interventions. I don't like anybody intervening who's not a clinician, who's not a physician, that wants to share valuable information of what's available now and what can enhance my abilities to be the clinician I need to be today.
Great. Well, we promised the audience that we would now, we would dive into some of the different formats that we use in CME, and wanted to get your perspective from as a healthcare provider as well as a faculty, and what we think is better for learning for these audiences, and what maybe some of the challenges are. So just diving right into that live in-person education, what do you think are the pros and cons of using that as an educational format for healthcare providers?
Yeah. Well, as far as enduring online education, let's talk about the pros and cons of that. As far as stuff that's there that I can go to anytime, I can do it on my own time. Like I said earlier, I can stop and start it when I want to, and I can review it. And usually there's good audio visual involved. I really love that, and I can really learn on my own pace. And there are some things that I save, and I say, hey, make sure that you look at this weekend, or maybe I'm traveling somewhere, I can look at it on an airplane or something, or wherever I'm waiting. I love that idea of online education that's there for me to do whenever I want to. As far as though, but there are some drawbacks to that. Obviously, I can get distracted, I can lose attention. And it's not like it's a live format where I really have to pay attention every single second, because if I miss it, I can't rewind it. I can't stop and start it. So I like the idea of things that I can go to whenever I feel like it. But let's talk about the pros and cons of things that are live. Again, you have a really captive audience in that situation. I love that idea because I'm there in the audience. I'm listening. I can't roll back time and go through it again. And in fact, if I've even paid for it, that makes me even more of a motivated listener. But again, as far as the online enduring education, which I can go to anytime, I love the idea of being able to go to it anytime I want to. And sometimes I'll even review it. If there's something really interesting, I'll go back to it again and repeat it to myself to make sure that it sticks in here, because some things don't stick as well as they should at times.
So for a live meeting, what is the preferred time length? Do you prefer going for a 1 week long conference? Do you like weekend meetings? Have you ever attended any of like the 1 hour, 2 hour dinner series or kind of grand rounds meetings? What is your preferred format in the live setting, and how is it easiest to best kind of get all of your CME?
Well, I've been both a participant as well as a speaker in every single one of those. You talked about evening ones, talked about weekend morning ones. I've even done weekend 2-day seminars. I've participated in 1 week seminars in various different situations and venues, whether they're a vacation spot or whether they're in a local area. I've done all those. What is my preferred? The answer is all the above, because every one of them offers something different. Give you an example. If I have a continuing medical education thing here in the Philadelphia area, and if it's interesting enough, I'll go to it because it's there, it's local. And if it's on a weekend, I'm not going to take time out of my day, and I'm going to learn something. That's a really attractive one. Secondly, let's say there's something happening on an evening, or let's say Saturday morning, just that, and the topic is a very important and interesting one for me. I'll go to that as well. But occasionally, it's nice to see that there's a venue occurring, let's say for 3, 4, or 5 days, in a place that I'd like to go. I'm going to be actually in a faculty for one in a couple of weeks in Scottsdale, Arizona. Really nice place to go. I've done a couple of other locations, many other locations which are really nice places to go. And what better thing to, let's say, go there maybe with family or what, and I'll attend some of the lectures, and at the same time maybe also have a little bit of rest and relaxation at the same time. So I like every single one of them. Fortunately, there are a lot of them that I can pick and choose from, both as a faculty and a participant. What I'm suggesting then is keep them all going, because there's a time and place for every one of them.
So let me jump in here. We have our first question from the audience. Of course, we presented 3 different ways for our audience to ask questions, and then somebody used a 4th way. So here's the question. Here's the question that came in. So, do you, as a healthcare provider, prefer lecture followed by Q&A session, or a highly interactive session that perhaps has a unique or innovative educational format?
Well, first of all, not all lectures are the same. Whoever's listening in, whether they are providers of CME or those that have been participants, I think first and foremost, very importantly, whoever's doing the presentation has to be a good presenter. I mean, the topic, of course, has to be interesting and this and that, but the presenter has to do a good job. And I'll get to the answer in a second. And secondly, a lot of times it's really good to have 2 presenters where there can be interaction between the 2. If there's enough interaction between 2 presenters, a lot of times they'll answer the questions in an audience so that there doesn't have to be this interaction going back and forth. I don't mind it that much, but it can sometimes break my train of thought, and it can also maybe postpone what I'm trying to get to, which is the end of the lecture. So the answer to the question is I prefer not to have questions during the time that I'm doing the presentation, but also if there's somebody else that I'm interacting with, it can oftentimes answer the questions. Let me give an example. Let's say I'm giving a talk as a primary care provider, and the other participant is, let's say, a specialist in the area, and he says something, and I, as a primary care provider, think of a question to ask at that time that I think somebody in the audience is probably thinking about. I'll then interject and I'll ask the specialist, well, what do you think about this? Or you said this, what do you think about that? I like that kind of a question and answer that, again, occurs between 2 presenters at the same time. But if I'm doing it by myself, I don't like for people in the audience to interject. I prefer to have the answers at the very end.
Great. Any other questions right now, Scott?
Not right now. So go ahead and you can get back to your list, Amanda. Sorry.
No, that's perfect. Thanks for asking. Okay, so getting back, just one more question about enduring or online education. What are some of the unique formats or preferences that you've seen that you enjoy for utilizing, kind of on-the-go education? Is it a monograph that you can read? Is it just, kind of slides and speaking? Or are there any other type of really engaging formats that you've found to be most effective?
Well, again, I like them all because they're sort of different and they're appropriate for different situations. If I am, let's say, on a plane, in an airport, that sort of stuff, I prefer to read. It's a lot easier. I mean, I'm not going to sit there and listen to something between or a presenter or 2 people talking or that sort of stuff. But on the other hand, sometimes if let's say I'm in the comfort of my own office, my own home, or even a hotel room or something, there may be some really good audio-visual presentation. I don't mind interaction between two speakers. I love a panel discussion. I like it when it goes back and forth. And I think that from what I have found with feedback I get from when I do presentations as a faculty, when there's 2 or more people interacting, especially if they're good interactive faculty members, it really breeds a lot of learning. That I like a lot. So if it's enduring that I can listen to, again, panel discussion is a really neat thing. But one other thing, I think that when there's any kind of a visual presentation, I love having any kind of, let's say, special effects, let's say we're talking about the heart, the kidneys, that sort of stuff. If there's any kind of a video that's going on that can show me, that really sticks. I've always liked that, a 3-dimensional kind of presentation about what's going on with a particular organ system, a particular disease state. That to me is really cool. I remember the first one that I saw was about migraines and showing the brain and the location of the brain, a 3D image that was going up and down and left and right, and maybe developing as a visual process. That I think was really important, and it really, really stuck. So that's an advantage of being able to get on the computer, watch something, and it really makes the educational format present the information that can stick in your head. But like I said, though, I do like it a lot more when there's two faculty members or more interacting with one another with, let's say, there's a slide deck on the side.
Great. Let's talk a little bit about technology challenges. We've heard the stats that there's astronomical number of people that have, smartphones and tablets. And what is your experience working with other healthcare providers or even serving as faculty? And our faculty, our doctors and nurses, are they using smartphones? Is that something that we should continue with to be able to provide them education in formats that they can use on their phone or their tablet?
Well, it depends on the age group. I mean, I teach a lot of students that come in, and every single one of them is either on a tablet, computer, or a cell phone. I don't think they even write anymore. Frankly, I don't even know they own any pens. I mean, everything is electronic. Our medical records are all electronic. So I think they're used to doing things electronically, again, through all those different methods that you talked about. They're used to it, so that's what they prefer. But as far as some of the older people, like maybe in my generation or so, they may have more of a challenge of getting online and that sort of stuff. I know that in the corporation that I belong to, there are about 50 or so different providers of all age groups, and some of them in the older age, they don't really like as much of the technology stuff, but the younger ones really do.
Great. Now, jumping in a little bit to some of the different types of formats that we've seen over the years as far as what people have delivered on for the education. And just kind of want to, discuss the pros and cons with you and maybe some of your experience and how you think it may be effective or not so effective for education. We talked a little bit about didactic lectures, and you mentioned you liked the interaction with maybe a faculty panel. But is there a place for just a straight up lecture with slides, and why would that be important for an audience?
When I started giving lectures in audiences, I remember before I did that, I thought to myself, this talk could be so much better if the speaker were a better educator, more engaging, and really knew how to say what he needs to say. He's so monotonous. All he's doing is staring at slides and flipping them, and it's so boring. He has such important stuff to say, he just doesn't know how to say it right. So the didactic lectures are absolutely fantastic if you have the right presenter. I mean, look, we all know this. We all went to high school, college, whatever. Who were our best teachers? Think about that for a second. They knew how to teach. So just because you know about a subject, just because, let's say, you're the world's leading authority on something, doesn't mean you're a good educator. So a didactic lecture is absolutely wonderful, but you have to have the right speaker. Look, subject matter is always interesting. When you go to a CME venue, all those things that you go to are pretty exciting and informative because they're sharing information with you that's new, that's different, maybe a review, etc. You're there because you want to learn. Somebody there that's, that's making it difficult and feels like, it's molasses going uphill and you're getting distracted, that can really take away from the information he wants to share. Bottom line, good didactic lecture means good speaker. Now, you mentioned a couple of other things, monographs. It's an oldie, but it's a goodie, and it does work. And like I said earlier, if it's there on my side, I can read it at my own leisure. It can be very effective. I mean, especially with computers, tablets, etc. I can scroll up, I can scroll down, bookmark it. It's really good. And at the very end, you have all these CME questions, and I can just click onto them, and then at the very end, get a response back as to what I did. It's really cool. There's another thing which you mentioned as far as case studies. I have mixed emotions about case studies. I know a lot of my colleagues love it when I present a case and then I work it through a lecture. It's very good, but there's a couple of caveats. It's got to be very applicable. I try to have as many case studies as I can, if I present it, actually true to life. In other words, as close to patients that I've really commonly seen. I don't like to invent a case which doesn't really appeal to or doesn't seem very realistic. So whenever I get, let's say, a CME company giving me a case presentation, I oftentimes modify. I say, that's not realistic, or that's realistic, or, you know, you didn't include this part of the vital signs, etc. So for case studies to be effective, they have to be true to life. They have to be a presentation that, let's say, a resident would present to his preceptor, to the attending physician. So that's very important about a case study. And if you're going to build it through a lecture, let's say, you have to make sure that it builds through. So it can be very captivating. It can direct your attention to the specific disease state, but it's got to be done just right. The other thing that you also have here for me to talk about is simulations. I think what you mean by that simulations is maybe special effects of what I talked earlier. Let's say three-dimensional video that builds. Is that right, Amanda? Is that what you're talking about with simulations?
That's part of it, but I know you also you actually worked on a few simulations with the DecisionSim platform, which is the branch learning and logic, and it's the more complex, I guess, patient cases, and really building more realistic scenarios, and just maybe how that type of simulation differs from like a traditional case study that you would present in a live setting. Yeah,
well, simulations I think are very effective. Again, what you're trying to do is to have the person who's learning there have that information go into his head and really make an impact and stick. But it also has to be not entertaining, but it has to be interesting. Okay. Again, as I said earlier, the worst possibility is a didactic lecture where the guy is boring. I mean, you'll start to, you know, play games on your tablet or whatever. So simulations are very effective because they can be captivating. They can keep your attention. I do like them when they're done right.
Okay, so we've got a bunch of questions that have come in here in the last couple minutes, so I'm going to kind of run through a few of them, if I may. So this question came through the educational measures text line. So here's the question. So I have seen a panel go wrong where one faculty may be from a more remote location and not have access to the same diagnostic tests as the other faculty who may be at a major university. Have you run into this issue, and how have you potentially overcome it?
Yeah, well, actually, that's a very good question, because we're a large country and there are different providers in different parts of what's going on. I'm in a suburban area. I'm very close to a city, but just about 50 miles up the road from me is kind of rural. So it's a different kind of a practice. In a panel audience where you have different kind of providers, I think it's a good idea to have those, because then they can share information that can be applicable to everybody in the country. So let's take, for example, the case of somebody who is in a rural practice says, you know, that doesn't apply to me. I don't have the availability to that test. Well, that particular doctor then is appealing to those people that work in rural areas. But the other one who's practicing in a city area and describes what he or she would do is applicable to those who are listening who practice in an urban area. So I think it's all very good interaction between the two when that happens.
Okay, so this question came in through our Google Slides Q&A line. So you talked a little bit about how you educate students these days. So are there any particular learning formats or learning preferences you're seeing amongst your students that may become more widespread in CME activities in the next 5 to 10 years?
Yeah, like I said earlier, they don't even write anymore. Gosh, I don't even think they even write cursive anymore. So things are really changing. They're all about electronic stuff. And they're also all about visual learning. Again, what I said earlier about video simulations, about things that progress, you know, looking at kidneys and heart and that sort of stuff that swirl around. These are the kind of things that they like. That's what really sticks in their head. They really don't like it when they have to read something, certainly out of a book, but also scrolling down. They don't seem to like that as much. So I think the trend is generally to have short bursts of information that have a little bit of audio-visual involved in it. I think that's what it's headed towards. That's what I'm seeing with my medical students anyway. And they tend to have a very short attention span too.
For sure. Okay, so one more question that came in on the educational measures text line. So what experience do you have as a either faculty member or learner participating in blended learning? So initiatives that combine both live and online activities. So where you might have, you know, a 1-hour live symposium, and then there is an adjunctive, 30-minute webcast, let's say, on the same topic that sort of where the content sort of builds off of each other.
So a live event, and as you're attending there, something that is presented that comes on afterwards, immediately afterwards. Is that what you're saying?
Well, a lot of times lot of times they'll come out, a month later, or there'll be a
Oh,
series of activities that
okay.
come out, every 2 weeks or something like that.
I'm glad you clarified that. A very important part of learning is follow-up. It's really cool when you go to any kind of, let's say, a live event, you learn something, you say, I'm going to apply this Monday to my practice. You go back and all of a sudden you start drifting back to where you were. If there's something that follows up on it, especially if there's incentive to follow up, it can be really, really helpful to have that information stick. I always love that thing. And I've always told CME people, you know what? It's great to have this, but please email these people and ask them how they're doing. Because a lot of times when you ask them what they're doing, it's a way of saying to them, please remember what you've learned. So asking is a nice way. And maybe even a small little burst. Remember we said this, these were our talking points. How have you applied these to what's going on with your practice? I think it's absolutely invaluable when that happens. In fact, it may even be necessary to have any information to stick, to have a follow-up non-live event.
Okay, great. So those are all the questions we have that have come in right now. So Amanda, I'll kind of let you jump back in.
Okay.
Sure. And Dr. Paul, I did want to follow up on one more format, and that's kind of the use of virtual reality or avatars or kind of like a gaming system for learners. Have you been involved in any of this, and kind of what are your thoughts? We're starting to see this pop up a lot more in CME activities, and do you see a difference in age groups and participation, and kind of just what are your feelings about this new delivery method and this new format of learning?
Yeah. Well, they're not as serious as the other ones, so I don't know whether they'll have as much of a captive audience, but they are entertaining and they are a nice way to learn. I think that if I had any one of those things, that let's say I was a participant I think I would do it, but I would probably make it one of the, let's say less attractive methods of trying to learn something. Because again, it does have sort of a connotation of being less serious and just be more attractive. Again, remember, this is a very scientific thing that we're trying to do. I have a white lab coat on, which is representative of me being a scientist. I want to get scientific information, which by nature tends to be black and white on paper, with graphs and bars and that sort of stuff. So I understand about having different methods like simulations, avatars, games, that sort of stuff. It does take away from the seriousness, but again, it can also have an entertaining value. And I will reach for it at times. I have participated in being a faculty at times, but I think it's the lesser attractive method of learning for most people, and it should really be a lesser method of learning for most people.
Great. Well, now I just want to jump into what we call outcomes, and so the effects of education on the learner audience. What are their takeaway points? We are asked as education providers to share this information, not only with the audience, but with our team, with those that are providing educational grants to support the activities. And it's always, difficult and hard for us to be able to identify areas where we can show that the education made a difference to the audience and that they're actually taking information back into their practice. Yeah. So I know you've talked a little bit about it and some of the engagement that's necessary, but is there any other talking points or formats that you find best supportive to transition the knowledge that learners have completed in that education to back into their clinical practice?
Yeah. Well, that's $1 million question. How much of an impact have we made on people? Well, follow-up, therefore, becomes critically important, in my opinion. How else are you going to know what a clinician is doing, what a physician is doing, what a nurse practitioner is doing, what a physician assistant is doing? These clinicians, how do you know that you've made an impact? The current guidelines, the current up-to-date way of doing things is what they're actually doing, as opposed to they've drifted back into what they're used to doing. There are many aspects that go into that. One of them is the topic itself. If the topic is very critical and going on with a clinician today, especially if he or she's being scrutinized, if it's diabetes, if it's cholesterol, if it's heart disease, if it's depression, if it's immunizations, these are topics that we are being scrutinized by all the time, whether it's the corporations we're working for, whether it's insurance companies, payers, etc. They're very interesting. We absolutely, as learners, want to have the best outcome. So whatever we learn, we will transition. And but if there are lesser topics, let's say topics that aren't showing up in those things, let's say, talk about, I don't know, anxiety or gout or whatever, nobody's looking over our shoulders. We may, let's say, drift ourselves back into what we used to do. So how do you get those clinicians to not drift back. And that's why I said follow-up is important. In my opinion, the best way to do that is to go ask questions. How are you doing with what you learned in this venue? Are you doing this? Are you doing that? Are you doing that? 4, 5, or 6 questions, which not only remind the clinician what he or she learned, but also ask the question, are you actually doing it? And I think 2, 3, maybe even 4 follow-ups like that would be invaluable to, number 1, remind the clinician to do it, but also number 2, get feedback as a continuing education company to see if they're doing it or not. There's one little problem with that. Clinicians can sometimes, well, bend the truth. Let's say I learned something that I should do this, and 3 or 4 weeks later I get an email. Are you doing it? I'll say, yes, I am, but no, I'm really not, but then I'll try to do it. Okay, so the information you get from email surveys afterwards can be skewed. So then how do you get the right information? Well, there are also methods of capturing what a clinician is actually doing. I don't know if it's done, but I know a couple of CME companies I've worked with have tried to do it, where because of the electronic method of gathering information, electronic medical records, I can, from a clinician, get information about what kind of diagnoses they're making, how often they're making it, and what they're doing with those diagnoses, and then get that same information from their electronic records. I think it's not as easy to do, but if you actually look at their behavior, if they track their behavior, but by some method other than a questionnaire, that may be one of the best ways of understanding whether the information you're trying to give to a clinician is actually sticking and making a change in their behavior.
That's great. I know one of the struggles that a lot of providers face is completion of those follow-up surveys. And so many times those are sent out 30, 60, 90 days after the completion of an activity, and the follow-up responses is, typically 2 to 5%. Is there anything we can do as providers to make you and healthcare providers want to complete those surveys for us?
Absolutely, and I'm glad you asked that question. Look, you got to understand, we're human beings. We love incentives. Okay, if you give a clinician an incentive to complete those follow-up questionnaires, surveys, which are inherent to them, are also a little bit of education, then it makes it much more worthwhile. And I bet you anything, you're going to get a lot of response. What kind of incentive? Well, perhaps, a gift certificate, or perhaps CME. If you complete this 15-minute questionnaire, you get 15 minutes of CME. It's got to have a little carrot. Look, like I said, we're human beings. We work that way. We work with carrots in front of us. So if you have some kind of an incentive for a clinician, I think it works really well. Or maybe some money off of the next CME venue that you're going to go to. Let's say a particular CME a clinician goes to costs, I don't know, for whatever, it costs $100. And if you say, well, the next time you go, if you do these surveys, we're going to take a certain amount of money off of your next attendance. I think that can have a good bearing on the follow-up questions, the responses, and probably also on the behavior of that clinician making a change for the better for that particular condition, disease state, medication, or whatever.
That's great. Thanks for those suggestions. Mm-hmm. And then also looking, have you ever been asked to review outcomes from an educational activity that you've helped develop or participate in? And yes. Why do you think this is important?
Yes, I have, and this is important on so many fronts. And like I said, though, the problem is gathering the information and wondering whether it's applicable, it's true to life, and that sort of stuff. Is only 2 to 4% responding? And why is it that only 2 to 4% responded? So yes, I have been involved in it, and unfortunately, when it's very few responses, I don't like it too much. But there are other CME venues I participated in where at least 50 or 60% of the attendees will give a response back. Now, those I hold with great amount of respect, because the responses in this specific one that I'm thinking of is 1-sentence responses for what they learned or what they liked or what they got out of it. And you go through them and you can see what they have, what they've written. And that, I think, is a very, very good way of understanding how that CME venue, what kind of an impact it had, how good it was, and if anything should be changed or whatever should be kept. So I like short answers, and I like a whole bunch of answers to come back, and I have been involved in them, and I find them to be very important.
And most of the time, I would say, our outcomes are delivered to internal teams as well as those that have supported the education through grants. How important is it to share the outcomes with attendees or other healthcare providers? And what would you think be the best methods to be able to share that with the healthcare community at large?
In other words, you survey an audience and then you share the responses with the audience. Is that what you mean?
Yeah, how do we present the results and the effect of this activity to a wider audience of healthcare providers?
Well, we clinicians are always looking to our left and to our right. What's the doctor, in the next room doing? In my case, for example, we have 5 clinicians in the specific building I'm in. What's he or she doing? And also, what's the guy across the street doing? What's the specialist doing? It's kind of interesting to know what they're doing. We're not as much as a competition, although we doctors love competition, but also just to see, how is everybody else kind of doing, the standard of care, let's say. So if I participate in a follow-up question and answer kind of a thing, a follow-up survey, and then I get the responses to that survey, it's very interesting. I oftentimes do get that. Sometimes, let's say, I'll get a survey and I'll say, look, if you take this survey, we're going to give you your responses of what everybody else did. I like that. I want to see what everybody else did. So I will truthfully answer those questions and wait for those responses to come back just to see how everybody else did. So I do like that sharing of information. And I believe most clinicians also do like it for those reasons that I mentioned, which is, like I said, we do like to see what everybody is doing and find out what's the standard of care with everybody else.
Wonderful. And just kind of wrapping up a little bit, the last question I have is, what can we do as education providers to provide better education to doctors, to nurses, to nurse practitioners? What do we need to be doing better to educate our audiences?
Yes. Here's the notations that I made for myself when you actually gave me this question. Number one and most important is address the needs of the audience. Know what they really want to learn about. And a lot of times it has to do with who is looking over my shoulders. What do the payers want me to learn? What do insurance companies want me to learn? What does the company I'm working for want me to learn? I have to satisfy them first and foremost. Okay, so I need to know what they want me to know. So pick the subject right depending on that. How do you know that? Well, you may have to survey an audience and say, is it important for you to learn about this, 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 and this? And they'll pick it for you. But there's also an educational need. Pick a topic that's really important. Something that maybe a payer isn't looking over my shoulder, but it's really important because patients are asking me about it, or I really want to know about it. Let's talk about, for example, hepatitis C. Payers aren't looking over my shoulder about it, but people are asking me about it. How do I identify it? How do I treat it? Transplants, who do I send for transplants? How do I need to know about that? So make the topic salient, applicable, for number one, whoever's looking over my shoulder, but also what a clinician really wants to know about. That's first and most important. The second is make all the different types of venues available. You mentioned all the different ones, and you asked me which is most important, and I answered yes, because in different situations, I'll want to use different ones. I will want to go to a live presentation over a weekend. I will want to go to a live presentation at let's say, a vacation area. I will want to go to a live one at night. Again, it depends on the topic, the location, and what's going on. And certainly there's another thing involved, which we haven't talked about, and that's this. Sometimes there are certain educational venues that are, let's say, 2, 3, or 4 days that I have to pay for. Keep in mind that if I pay for something, if I pay $200, $300, or $400, boy, am I incentivized to learn. Keep that in mind. Again, if you pay for something, you're much more inclined to learn. That is also another incentive. So what can you do to provide better education? Make tops. Number two, have all the different kind of educational venues. And sometimes you see if you can charge the audience a certain amount of money to attend. And finally, 2 other things. Keep the audience attentive. Make sure you have a good speaker. Make sure you have all the different kind of audio visuals, whether they are simulations, whether they are avatars, whether they are all these different kind of things we talked about. Keep the audience engaged, keep the audience attentive, and finally, follow up. I hate to say this to you folks, but if you have any CME venue and you don't have a follow-up questionnaire that you're sending, you might be losing out on a very important opportunity to have that educational information stick in their head. Make sure you follow up and give them an incentive to follow up. If you fill out this questionnaire, we're going to give you this, that, or whatever incentive. These are some of the things that are so important right now in what's going on with healthcare education.
Okay, great. Well, there's a few more questions that have come in, so we've got a couple more minutes, so I'll kind of run through a couple of them. So this is another question from the Educational Measures text line. So what training, if any, did you receive to become a more engaging speaker? Whether it's a live venue, whether it's this venue. I mean, obviously you're very animated, so I think that, and I think that resonates very well. So I think this person is looking at implementing training for sort of new speakers for CME programs. So what sorts of things should they focus on, and what has kind of been your experience?
Good question. Uh, Inherent in that question was, I'm an engaging speaker. Thank you. But there are two factors that need to happen for a speaker to be an effective speaker. One is they have to be trained right. There are certain facets of training that are very important. I remember in my earlier days, the thing that really helped me to be as engaging as I could, as effective as I could, was watching myself, having a videotape of myself to watch myself to see, geez, I should do this differently. I should do that better. Oh, that was really good. I should continue to do that. I practiced speaking. Any kind of a talk that I did, I practiced it in front of a mirror. So with anything else, whether you're speaking, playing basketball, being a doctor, practice makes perfect. But secondly, there is I guess, a certain part of innate ability to be able to speak. I just come from a family of speakers, my brothers, my father. Everybody has a way of just presenting. So you have to have a little bit of innate ability, but you do have to have training. And the right kind of training with innate ability, I think, can translate to an effective speaker.
Okay, now how much do you feel that there is sort of I guess I think this person called it sort of a credibility issue, in that there are physicians out there who sort of pick the easy ways to obtain CME credits. They'll just basically click through an online activity, or they'll claim they read a monograph and claim credit for it. Is that a widespread problem, and sort of how do we as CME providers potentially overcome that?
Yeah. My feeling is that it's not a widespread problem. It's there, it exists. Sometimes some doctors just want to get the CME credit. But again, most clinicians really find this to be a noble field, a noble occupation where you really have an inherent need, a motivation to do the right thing. All of us clinicians have that innate need to do the right thing. It's part of our job. So yes, I think that some clinicians may at times just mail it in, so to speak. But I think most of them really mean what they say.
Okay, terrific. With that, I would like to certainly thank both Amanda and Paul for their participation in this wonderful session. For those of you who are watching this session and are watching any of the CME Palooza sessions, there is a survey link. It's actually at the bottom of the live tab. Derek kind of switched it up on me. So we certainly hope that you go in and complete that short survey. We've only got a couple questions on there, and it kind of helps us to help plan future CME Paloozas. There are always a few sessions that we get ideas from folks who have completed our surveys. And for anyone interested in watching the next live CME Palooza Spring broadcast, we will, at the end of this broadcast, we will queue the next one up. So you just need to refresh your browser, and we will start our next session right at the top of the hour. And so with that, I'd like to thank Amanda. I'd like to thank Paul, and I'd like to thank everybody for tuning in, and have a good morning and afternoon.
Thank you all.
Thank you.